So I'm going to be talking today about health insurance policy and women's perinatal health. So as for some background, as many people are well aware, the United States has our maternal and infant health measures are typically poor compared to our peer countries. So as you can see here in this map, this is showing the rate of preterm births. So it's basically just the percent of births that are born before 37 weeks gestation. And you can see that the US, our rate is usually around 9–10%. And you can see that that's quite a bit higher than many of our peer high-income nations and also middle-income nations. So the rest of North, Central, South America, Europe, Asia, all typically have lower rates than we do. We also have persistent racial and ethnic inequities in maternal and infant health measures within the US. So here, this is also the percent of births that are preterm. You can see that women identifying as non-Hispanic Black have about 50% more likely to have a preterm birth or preterm delivery compared to women who identify as white or Hispanic. And especially concerning is the fact that the difference between these lines, that disparity has not really changed over the 12 years shown here, but it really has not changed over many decades. If you look at other measures of maternal and infant health, you'll see similar things. So this is the maternal mortality ratio. That is the number of deaths during pregnancy or the first 42 days after delivery due to pregnancy-related causes divided by the number per 100,000 live births. So you can see, again, the US is the red line. So we have a higher maternal mortality ratio than countries like the UK and Canada. But more concerningly, our maternal mortality ratio appears to be increasing over time, whereas many other countries, it is decreasing. And some of that increase is thought to be due to better measurement and surveillance, but not all of it. Similarly, there are persistent inequities in maternal mortality. This is showing pregnancy-related deaths. It's basically the same thing as maternal mortality, but instead of just the first 42 days after delivery, it's a year. So you can see that women who identify as American Indian or Alaska Native are more than twice as likely to die during pregnancy or the first year postpartum compared to women who identify as white. And for Black women, that is about almost 4 times as high. And we know that those inequities are not completely explained by socioeconomic status. So here we see that Black women with a college degree or a graduate degree are still about twice as likely to die during pregnancy or the first year after delivery compared to white women with a high school education or even less than a high school education. So an important gap in our understanding of why the US has such high rates and persistent inequities in adverse maternal and infant health outcomes is that traditionally a lot of the research on trying to understand that has focused on kind of narrowly on the 9 months of pregnancy, so that lead to a delivery. But we know that those 9 months are really only represent a fraction of the life course of a person who's pregnant or delivers a baby. And so increasingly, there's a lot of interest in understanding what factors leading up to conception and pregnancy might affect the health of individuals and the social well-being of individuals at the time that they arrive at pregnancy. So there's increasing interest in this preconception period. And although that often just refers to a few months or a year prior to pregnancy, really, we need to be thinking about exposures and experiences from infancy all the way up to pregnancy. So this could include health behaviors, education, occupation, stress, discrimination, et cetera, across the life course. We're also increasingly interested in the interconception or interpregnancy period. So this is an important window for, women are kind of already in the healthcare system, and this might be an important window for intervention and prevention and improving health. And then we are also interested in the postpartum period. So how does pregnancy affect the mental and physical health of mothers and fathers in the first year postpartum and really on through the rest of life? So this, a lot of my research really covers this whole spectrum. So I've done work on early life stressors and pregnancy outcomes, pregnancy and later life health of women. But what I'm going to be talking about today is really just the kind of short preconception, interconception, and postpartum periods. And so I'll refer to that as sort of the perinatal period. So one thing that we know about this period, and one thing that is unique to the US and that may be contributing to our high rates of adverse outcomes and to those inequities that I talked about, is that there's a high rate of insurance churn during this time. So what that means is that people change between maybe private insurance, different types of private insurance, public insurance, no insurance. And that's unique to the US because of the way our health insurance system is structured. It's typically tied to employment. So there are a lot of changes in employment around the time of pregnancy, delivery, early postpartum. And so people tend to lose insurance or gain insurance. And this is particularly important for low-income individuals because of the way that Medicaid is structured, particularly before the Affordable Care Act. So before the Affordable Care Act, in all states, low-income women would typically qualify for Medicaid upon becoming pregnant. And so if you look at this blue line here, you can see that if pregnancy is typically starts about 9 months before delivery, you can see that the percentage of women with Medicaid coverage increased from about 9 months before delivery up until delivery. And in fact, this chart is a sample, but if you look at all births in the US, about 43% of births are covered by Medicaid. So it covers a lot of births in the US. But many of the delivering people who deliver those births didn't have Medicaid and may have been uninsured prior to becoming pregnant because they only became eligible because they were pregnant. And so this study here showed that about 65% of deliveries that were covered by Medicaid, those individuals were uninsured for at least 1 month prior to delivery. In the 9 months prior to delivery. Second, Medicaid coverage during pregnancy ends 60 days postpartum. So individuals who obtain Medicaid during pregnancy lose it again 2 months after delivery. So there are kind of big gaps in health insurance coverage prior to pregnancy and after 60 days postpartum. For low-income individuals. So this map is showing that in all of the light blue states, this is from around the time that the Affordable Care Act was passed. So in all of the light blue states, the income eligibility guidelines for Medicaid were 0. So basically, there was no income eligibility guidelines. You could not qualify for Medicaid because you were low income. Prior to the Affordable Care Act, Medicaid primarily covered disabled people. And there were some states where parents could qualify if they were low income, but a person who was not yet pregnant and didn't have any children and was low income would not have Medicaid, except in those blue states. So you can see that, for example, in New York, which is in this medium blue category, the income cutoff was somewhere around 100%. So if you were below 100% of poverty, you would qualify for Medicaid. The Affordable Care Act was passed in 2010, and the idea was that Medicaid would be expanded to all Americans with incomes less than 138% of the federal poverty level, regardless of disability, pregnancy, being a parent, anything else. So ideally, this would have covered a lot of low-income individuals who would otherwise, if they're women getting pregnant, they would only qualify during pregnancy. However, in 2012, the Supreme Court ruled that states could opt into or out of this Medicaid expansion. So when it went into effect in January 2014, only the states in blue actually expanded Medicaid. So this creates a natural experiment where there are some states that adopted Medicaid expansion. So in those states, low-income individuals now are eligible, and other states that did not. And so this is the natural experiment that we take advantage of in the research I'm going to talk about. Since 2014, a lot of other states have expanded Medicaid. So this is showing 2018, all the dark blue states expanded Medicaid. As of today, I think there's only 12 states left that have not expanded Medicaid, but our research, our study period is more ending around 2017. So the idea and the hypothesis is that by expanding Medicaid to low-income individuals, this preconception period and this postpartum period where typically people would lose Medicaid or not have Medicaid, they would now be eligible. And so that dark blue line showing Medicaid coverage would straighten out and people would have more consistent coverage prior to conception, during pregnancy, after pregnancy, between pregnancies, etc. So the central hypotheses of the work that I'm going to be talking about today are simply that the Affordable Care Act's Medicaid expansion increased insurance coverage and access to care for low-income women prior to conception and during the postpartum period, but not during pregnancy. The Affordable Care Act did not impact Medicaid expansion during pregnancy or Medicaid coverage during pregnancy. And so the first aim of our work was to examine how this increased insurance coverage, whether it translated into improved health among women of reproductive age and especially prior to conception. And so we focused in 3 areas that are shown here. These are areas that the CDC emphasizes are important for improving pregnancy health. Our second aim was to look at the impact of the Medicaid expansion on reproductive health. So we hypothesized that contraceptive behaviors might change because people would be able to access and afford prescription contraception or contraception that requires visiting a healthcare professional. And we also hypothesized that fertility and childbearing decision-making might be affected because it's been shown that increased financial stability affects fertility decisions. And then our third aim was to look at the impact of Medicaid expansion on pregnancy health and pregnancy outcomes. But as you can see, we hypothesized that this would only be affected by preconception health and reproductive health, and not directly by Medicaid expansion, because as I said, Medicaid eligibility during pregnancy really didn't change because of the Affordable Care Act. So all of this work is funded by an R01 from NICHD, Policy Change in Women's Health. And then we recently received an administrative supplement. And so that is looking at measures of postpartum health and impacts on that of Medicaid expansion. And so we're currently looking at mental health, postpartum checkup, so utilization of care, postpartum and interpartum contraception, and possibly mortality, depending on our sample size. Okay, so for all of this work, we use the same study design, the difference in differences design. So some of you are probably very familiar with this, but for folks who aren't, I'll explain it a little bit. So This is an analytic strategy that's used when you have a natural experiment or a quasi natural experiment. So on the x-axis, you have time divided into the pre-intervention and the post-intervention period. The blue line in the middle is when the policy goes into effect. And then on the y-axis, you have whatever outcome you're interested in. And so you have one group, the green group is your kind of your control group. So that's the group where the policy did not go into effect. So in our work, this is the states that did not expand Medicaid. And then the red group is the group where the policy did go into effect, the intervention group. So to use this analytic strategy, you have to assume, and you need to check these assumptions, that the time trend in the outcome in the intervention group, the red group, and the control group, the green group, that the time trend is the same. So the two groups can have different levels of the outcome. So you can see that the outcome in this example is higher in the intervention group at the outset, but the two lines are traveling in parallel. So the change in the outcome over time is the same in the two groups. They can go up together, down together, straight across together, but they need to have a constant, there needs to be a constant difference between the green and the red groups in the pre-intervention period. And the reason for that is that you use that constant difference to extrapolate out. If you see the red dotted line, you're extrapolating out to predict the observed value of the outcome in the intervention group if the intervention had not happened. So that's your counterfactual, your unobserved counterfactual. And so that's that red dotted line. So then the way that you assess the effect of the intervention is you take the difference between the observed value in the intervention group at the end of your study period, which is the blue dot at the end of the red line. You subtract the difference between the two observed final values, those two blue dots. You subtract the constant difference. And so that's the difference in differences. And the remaining amount is the intervention effect. So the intervention effect is basically the difference between the observed value in the outcome in the intervention group and the expected value had the intervention not occurred. So for those of you who like to look at equations better, this is what the model looks like. You have your outcome, y. In this case, it's the intervention occurs by state. So state is the unit of analysis. And then beta 1 is the difference in difference estimate. So if the person lives in a state that expanded Medicaid, they get a 1 for expansion. And if their outcome was observed after the intervention went into effect, they get a 1 for being post-expansion. And so then beta 1 is that estimate. And you can also include dummy variables or fixed effects for time, in this case, year, or you can use month, state. And then you can also include individual or state level covariates. So for our study, we had to first define our intervention and control group. So the intervention group are the states that expanded Medicaid. These are states that expanded in 2014, and then a few others expanded in 2015 and 2016. And then these are the states that did not expand Medicaid. There's also a few states, 5 states that, or 4 states plus DC, that expanded Medicaid prior to 2014. And so typically, we either exclude those states or consider them control states. And then we also have to define that pre-post period. And so this is a little bit more complicated than just when was the outcome observed. For one thing, we hypothesize that it takes a while for people, once a state expands Medicaid, we hypothesize that it might take up to a year for people to become aware of their eligibility, apply, enroll, and then use the Medicaid, then their new coverage to, access care or improve health. And then with our pregnancy outcomes, we're hypothesizing that all of that happens prior to pregnancy. So we are looking at Medicaid expansion prior to conception. So essentially, we define people as being exposed or being in the post-intervention period if their state of residence expanded Medicaid at least a year prior to either the outcome we're looking at, or for the pregnancy measures, a year prior to conception. Okay, so I'm going to kind of go quickly through a bunch of results just to sort of give you the overview of what we're doing. I'm happy to come back to anything in the Q&A that I don't talk about in detail. So first I'm going to talk about, actually this is sort of more of a preliminary study that laid the groundwork for the R01 that we ended up getting. So in this study, we were really focusing on women of reproductive age. We didn't know if they were pregnant or were going to get pregnant. And so it's more about preventive health. And so for this, we used the Behavioral Risk Factor Surveillance System, BRFSS. This is a statewide representative survey. It asks a bunch of questions about health insurance access, utilization, behaviors, et cetera. For this study, it was an ideal data set because it has annual data at the state level, which is publicly available, and it has a large sample size, which is required for these kind of analyses. It isn't an ideal data set in other ways because it does have poor response rates, and many of the questions aren't ideal measures, but for this study, it was the best data set to use. So as I mentioned, we focused on women of reproductive age, and we did limit it to those who would likely be eligible for Medicaid. So if their household income was less than 138% of poverty. And so we had about almost 60,000 individuals in the study. So we looked at a variety of outcomes here because this was sort of exploratory. So we looked at whether their healthcare coverage changed, whether they had insurance or not. It didn't ask specifically about Medicaid. We asked about healthcare access, several measures of healthcare utilization, measures of overall physical or self-rated health and physical and mental health. Among those with diagnosed chronic diseases, the survey asks whether they're taking medication. And then we also looked at some health behaviors. So I'll jump right to the results. And so what this is showing you are those difference in difference estimates. So on the y-axis is the percentage point change in the outcome that is associated with the Medicaid expansion. And these models are adjusted for a whole bunch of individual level variables as well that you can see at the bottom. So and so these are all statistically significant. The other outcomes were not. So I'm just showing you those. So as you can see, we found that Medicaid expansion was associated with a 9 percentage point increase in having health insurance among low-income women of reproductive age. It was associated with a decrease in avoiding care due to cost, an increase of about 5 percentage points in having had a checkup in the last year, and pretty large percentage point increases in taking medications if diagnosed with those chronic diseases, high blood pressure or diabetes. So this suggested that, although it's preliminary, this suggested that the Medicaid expansion did increase health insurance coverage and access and utilization of care and some measures of preventive care among women, low-income women of reproductive age. So then moving on to more of a focus on pregnancy, our first study looking at preconception health is coming out in publication soon. I think it's already online. And so this study uses the US Vital Statistics natality data, which is almost all birth certificates in the US from 2011 to 2017. This is also a useful data set for studying this because it does have almost all births across 50 states and DC. We know when births occur, so we can measure whether those delivering individuals would have been eligible for Medicaid prior to becoming pregnant. However, the validity of the measures that we're using for preconception or pre-pregnancy health are probably not great. So I'll show you what those are in just a minute. So we focus on singleton births to women who are 18 or older. So that ends up being about 20 million births. So the measures of preconception health that we use were using cigarettes in the 3 months prior to pregnancy, pre-pregnancy body mass being overweight or obese or underweight, and then indicators of pre-pregnancy diabetes or hypertension. So again, jumping to the results, you can see that there are not any significant associations between Medicaid expansion and any of these outcomes. So our hypothesis was not supported with these data. I'm going to jump to AIM 3, which is pregnancy health, because it's really part of the same study. So still using that birth certificate data. However, some of the measures that we have for pregnancy health and outcomes, they have a little bit higher validity probably than some of those pre-pregnancy variables. So we know that birth weight has pretty high validity. Accessing prenatal care in the first trimester is considered moderate, but then some of the other behavioral variables and pregnancy complication variables are thought to, they're not thought to be very sensitive measures. So the pregnancy related outcomes that we looked at were the health measures were whether the person accessed prenatal care in the first trimester, use of cigarettes in the first trimester or at all throughout pregnancy, and then indicators of gestational diabetes, gestational hypertension, which includes preeclampsia and eclampsia. And then the outcomes, the pregnancy outcomes we looked at were early preterm birth, and birth weight for gestational age. Again, I will go to the results. And again, you will see that there are no significant associations between Medicaid expansion and any of these outcomes. So again, our hypothesis here was not supported. So you'll notice I skipped AIM 2, which is the reproductive health AIM. And so we are still working in this area and still getting access to the data set that we hope to use to focus on this. But we do have some findings, and the credit here goes to my research team, not me. So the first study I'm going to show you is Dr. Gartner, a postdoc in our research group. She talked a couple weeks ago, and she didn't mention this, but another project she's working on is looking at the impacts of Medicaid expansion on live birth rates. So how many babies are born, and does that differ by any characteristics? And did Medicaid expansion impact that? So this work is under review, so I'm not going to reveal too much yet, but I did just want to show this illustrative figure. So the words are kind of small, but the dark line at the top, that is birth rate in expansion states over time. And then the bottom dotted line is, the top line is non-expansion states. The bottom line is expansion states. And so you can see there are differences between the two, but the trend over time is not very different. So birth rates have been dropping off over time in all states in the US, and there do not appear to be major differences between expansion and non-expansion states. So one of our hypotheses had been that perhaps the Medicaid expansion would affect who decided or who decided to become pregnant or became pregnant, and that might indirectly affect pregnancy outcomes, but this data is not suggesting that that's the case. Similarly, in this vein, Colleen McCallum-Bridges, who's a PhD student in our research group, published a study in Contraception, and this is a little different. So she was focused on another aspect of the Affordable Care Act, the contraceptive mandate. So that required that all new health insurance plans provide FDA-approved contraception without cost sharing. And so so what she's doing is comparing, looking at rates of or percent of individuals reporting that they had an unintended pregnancy before the mandate and after the mandate. And she also looked at long-acting reversible contraception. And so that's the most effective version of contraception and needs access to and interaction with a healthcare provider. And so what you can see that she found here, the long-acting reversible contraception is, it's not showing up really well, but it's the left bars. So you can see that on the left-hand side is the before the contraceptive mandate. About 9% of women reported using those LARCs. And then after the mandate on the right side, that increased to about 13% of women. So the mandate did affect percent of women using effective contraception, and that's been shown in other studies. The darker gray bars on the right show that prior to the mandate, about 5.5% of women reported having an unintended pregnancy in the prior year, and after a little under 5%. So there was a small decline, but that wasn't significant. However, she did find that that decline in unintended pregnancy was a little larger in women with government-sponsored insurance, which includes Medicaid. So this suggests that Medicaid and other aspects of the Affordable Care Act may be working together to affect reproductive health. And so that's what her dissertation is about. And she recently received an F-31 grant to work on that project. So stay tuned for more findings related to the Affordable Care Act and unintended pregnancy. So then finally, going to our sort of in progress work, which is on postpartum health and continuing work on preconception health as well, because we're not really done with that. We're now using a different data set, the Pregnancy Risk Assessment Monitoring System, PRAMS. This is a statewide survey that is given to a representative sample of individuals who delivered a live birth. And typically they receive the survey and return it within about 3 to 6 months after delivery. So it's done at the state level. And the survey includes questions about preconception health, pregnancy health, and postpartum health. It's also linked to the birth certificates. And so it's really the only national data over time on preconception and postpartum health. And so that's why we're using it. It does have some limitations. Response rates are low and vary by state. And data from states with the lowest response rates is not included. So we don't actually have all 50 states. So for this study, we're using data from 2012 to 2018. And we are focusing on, again, low-income individuals. So based on their household income, we have about 112,000 delivering people who completed the survey. So we've started by focusing on mental health, and I'll explain why in just a minute. And so, as I mentioned, we're kind of looking at both pre-pregnancy and postpartum health at the same time, mental health at the same time. So the measures that we have from this survey are not all completely ideal, but what we have is whether the person was screened for depression prior to pregnancy. It's really whether they were asked about depression, but we consider that probably a proxy for screening. And then whether they were told by a healthcare worker that they have depression. And then postpartum, they're actually asked about symptoms. So they're asked how often they felt down, depressed, or hopeless. If they respond often or always, they're considered to have that symptom. They're asked how often they've had little interest or pleasure in doing things. If they respond often or always, they're considered to have that symptom. And then we combine the two together. So if they answer yes to either question, they're considered to have a depressive symptom. So again, I'll go to the results. And so again, this is showing the percentage point change in the outcome. So you can see that Medicaid expansion appears to be associated with almost a 2 percentage point increase in screening prior to pregnancy, and about a 2 percentage point decrease in individuals reporting that they were told they had depression prior to pregnancy. However, Medicaid expansion does not seem to be associated with the postpartum depressive symptoms. So I said that I would explain why we're starting with mental health. And the reason for that is really because of a related area of research that I'm working on. So this is showing data from another study that I worked on with a colleague in California. And so we looked at postpartum, the first 12 months postpartum mortality rates using about 1 million deliveries in California from 2010 to 2012. So the y-axis here is incidence rate of these different cause-specific mortalities in the postpartum period. And you can see that drug-related causes were the second leading cause of mortality in the postpartum period. And then suicide is also a contributor. Drug-related causes and suicide combined were they were 18% of total postpartum mortality. And so this has also been shown in other states. In fact, the contribution of drug-related causes and suicide to pregnancy-related mortality in other states has been found to be even higher, and it's thought to be increasing. And so although these are not necessarily related to depression, there is certainly a mental health, substance use, social concern area of concern during the postpartum period and during pregnancy, and these are kind of all related. And another thing that we found in this study is that we looked at, for those individuals who died of a drug-related cause or suicide, we looked at their emergency department and inpatient hospital use between delivering the baby and their death. And about 3/4 of those who died made at least one visit to the emergency department or an inpatient visit to the hospital, and almost 40% made 3 or more visits. So there's a high rate of healthcare utilization, particularly emergency department utilization, for these individuals who are dying of these causes during the first year postpartum. And there's a hypothesis that this may be actually related to healthcare and health insurance and Medicaid, because as I mentioned, individuals with Medicaid coverage lose it 60 days after pregnancy. They may be uninsured, or they may have different kinds of insurance, going back and forth between different kinds of insurance. And so it seems that people are kind of falling through the cracks of what we would hope would be more preventive care, outpatient care, treatment. And so there's a lot of interest right now in expanding Medicaid for an entire year postpartum instead of just 60 days. And just a lot of interest in general in how we can improve mental health and substance use support and treatment during the postpartum period. So to summarize all of the many findings that I've bombarded you with, so far we have found that Medicaid expansion under the Affordable Care Act appeared to increase insurance coverage, utilization of preventive care, and management of chronic diseases among women of reproductive age, and may be associated with reproductive health, particularly unintended pregnancy, in conjunction with other aspects of the Affordable Care Act, but stay tuned for more on that. We did not find that Medicaid expansion impacted live birth rates or measures of preconception health, or pregnancy outcomes based on the birth certificate data alone. And our preliminary work has shown that Medicaid expansion may have increased pre-pregnancy depression screening and decreased diagnosed depression pre-pregnancy, but that did not appear to impact postpartum depressive symptoms. And then the last study that I showed you, we found that drug-related deaths, suicide, and also homicide are important and under-researched causes of death in the postpartum period, and that individuals who die of those causes have high emergency department and inpatient hospital utilization, which may suggest a lack of preventive or outpatient care or treatment. So to conclude, what I would say, kind of my current place of thinking about all of this, is that we do think that expansion of Medicaid to low-income individuals outside of pregnancy is important. It has been shown to reduce insurance churn and financial stress, and it may increase utilization of preventive care over the long run, although we didn't see, any short-term impacts on pregnancy outcomes. It's also likely that health insurance alone is insufficient to improve some of these intractable measures of preconception health, like obesity, high blood pressure, health behaviors. We know these are tough to change, and health insurance is probably not enough. And similarly with pregnancy outcomes, we know that there's a lot of other important structural drivers, racism, discrimination, social and socioeconomic status. And so, there obviously needs to be efforts in many areas and not just giving people health insurance. But we do think that mental and physical health are of particular importance in the postpartum period, which extends for at least a year, not just 60 days, and that many delivering persons may be falling through the cracks in terms of medical care and other social supports during this time, and that's an important area for future work that we intend to be doing. So that's all I have. I do want to thank my funders and the collaborators on the work I presented today. I have many other collaborators, but I want to thank Dr. Kastner at the University of Chicago and Dr. Goldman Meller at the University of California, Merced. And then I am very grateful and indebted to my research group. We have a couple great undergraduates, graduate students in my group, Colleen McCallum Bridges, I'm sorry, I didn't get the last name fully on there, and Yasi Zamani Hank in this department, and Caitlin Hedinger in economics, and then my postdoc, Danielle Gartner. So thanks so much for your time. I'm happy to answer any questions or take comments.
Thanks, Claire. So the floor is now open for questions.
I'm going to stop sharing.
I have a quick question about how you're talking about insurance after the 60-day period. That's just for states that that don't have that expansion piece for the low income, right? You were comparing those that have it versus those that don't. I just want to make sure I understood it right.
Yeah. So now that, some states have expanded Medicaid, the Medicaid eligibility is still typically higher during pregnancy. So in some states, it's up to 300 or even more % of federal poverty. So there are lots more people who qualify for Medicaid when they become pregnant than those who would simply qualify by being low income. So there are proposals in many states, or in some states, and also at the national level, that anyone who qualifies for Medicaid during pregnancy should be able to keep it for at least a year after delivery. So that would extend Medicaid for even more people, because there's some people who qualify for Medicaid during pregnancy who kind of have like a middle income.
Okay, thank you.
Claire, it's Jim. Congratulations. That was a great talk, and I appreciate your bringing in the drug angle. And I wonder if you could tell us a little about, maybe you don't know this, but which drugs are more likely to be involved? Are these opioids, prescription opioids, heroin, fentanyl, cocaine? Do you have any idea?
In that study, we weren't able to look at it. We didn't know what drugs. In other studies, I mean, opioids are a big part. I would have to go back and look, but I think that that methamphetamine is also a contributor. I'd have to go back and look for sure, though. And my collaborator is the substance or the drug use expert, so she probably knows more than me. But I mean, opioids are definitely a big part, but it's not all of it. Yeah. And it's, I think it's probably changing around over time, but this isn't something that's like monitored or, that we have a really good handle on, especially at the national level. Most of the data that's there from other states is from mortality reviews, where they really dive into the, whatever information they have about people who died during pregnancy or postpartum. And so, we don't really know at the national level what's going on.
And then, if I can piggyback and ask a methods question, if the other people have their hands raised or have questions, it's all right. You can cycle back later, or we can talk later. In terms of the differences methods, what are the major concerns that reviewers voice when they evaluate your contributions in that area? I think that people would be interested to know, what are the main issues that reviewers bring to your attention in that context. Anyway, yeah. Thanks very much.
Well, reviewers don't always bring as many concerns to our attention as like we have in our heads. And I think we had more concerns when we were writing the grant proposal. I think a lot of people are almost accepting this method as like, oh, it's totally fine, because so many papers are coming out on Medicaid expansion using this method, but there are limitations. So one simple kind of basic limitation is that the sample size is restricted somewhat by the number of states, not just the number of people. So even when we have, thousands or millions of observations, you're still, comparing using states. So there can be power concerns. The other limitations are that even though we control for states and we look to see if the trends and the outcomes between the expansion and non-expansion states are parallel prior to the intervention, everybody knows that there are big differences between states that expanded Medicaid and those that didn't, that are hard to address. And so there are, I think there's a method that I'd like to start trying to use, where you create a synthetic control group. So you combine data from you kind of weight the control states to make them more similar to the expansion states based on other characteristics. But one of the things that we've been doing that I didn't talk at all about, but that I think is really cool, is that I just presented this as Medicaid expansion, yes, no, because it's simpler. But for both of the published studies, we also created a completely different variable. It's a continuous variable, and it's the predicted probability of being eligible for Medicaid. And so to do that, we go back to American Community Survey data. We actually have where there's actually income And we create these demographic subgroups based on like race, education, marital status, parity, or having children in the household, state, year. And so you can figure out, what's the probability or what's the percentage of people in each of those subgroups that is probably eligible for Medicaid at any given time in any given state. And then you can apply that probability back to the people in your actual study. And so that gives you a continuous measure. So then it's not as reliant on the difference in differences model. And so it gets around some of those. But it actually asks a slightly different research question. So in some cases we've found slightly different, findings.
That's great. Thanks a lot.
It's Nigel here. Let me put my picture on. Thank you, Claire. That is a wonderful talk. And it's really so important to have someone looking at policies, large-scale policies and their effects on outcomes. I think the difficulty you encountered is the time frame, the time it takes for outcomes to really change. And it's not short term. It's not widely appreciated that when Medicaid first came, Medicaid and Medicare both came in the mid-60s. And it was followed, Medicare, they were both followed by a substantial change in mortality. Medicare changed the mortality pattern for elderly adults substantially because previously a lot of elderly adults were not getting medical care prior to, and Medicaid, what it did, it opened up the possibility of premature care to poor women. And a lot of the early premature work was done in municipal hospitals. It couldn't have been done, the development couldn't have been done without Medicaid funds. Also Hill-Burton, the construction of hospitals after World War II played a role. So these things take a while to evolve as social policies come about, but I can't say enough about how valuable it is that you're opening that line of research and also bring a lot of good young people too.
Yeah, unfortunately, it gets hard to look at, long-term effects because then so many other things change. We will be able to look further out as data becomes available. So it's possible we might be able to do that.
I have a quick question. Also, like a piggyback on Jim's, I guess. Oh yeah, thank you for the talk. It's very interesting. I enjoyed it because I smell when you talk about differences. But when earlier you said you include states and you examine the prior trend if they're parallel or not. I remember one of the papers, the live birth rate, you can see that prior to the change, it is parallel. I saw your picture on the presentation, during the presentation. But you didn't show others. So I was wondering if for all these outcomes that you had studied, do they always show the parallel patterns, or which one of them are more likely to satisfy the assumption?
So in both studies, so in the study of using the birth certificate data, there were a few that were not parallel. However, we didn't have any findings anyway, so it really didn't matter. With the BRFSS data, there were also a couple that were not parallel. I can't recall which ones they are, but I can go back and look. So we indicated that you should kind of take those findings with more of a grain of salt. So usually, the trends are not like perfectly parallel. The live birth rate data is unique in that it's so parallel. But you're more just looking to see that they're not, substantially going off in different directions.
I also went from difference in difference to synthetic control on some studies. And there are these parametric and then there are non-parametric methods. I was using like counties in Michigan, so you have 83 units instead of 50 states, right? And then my conundrum is like you find these different weights depending on the number of period. Like sometimes if you have missing data, some units get dropped, and the number of period also is important because it's going to be like a completely weighted average kind of right before the intervention. So like you said, what is the interpretation for that? And when I try this outcome, some result shows me the parallel trend, sort of, but some of them goes up and down, like they overlap with each other, not really trending anyway. So I don't know what the interpretation for this kind of weighted average is. Like what do you think that, is there a causal interpretation like we always say or not?
I don't think I've thought about that question. I haven't done the synthetic cohort yet, so I really, I know that it's useful, and I feel like I've seen a couple papers start to do it, but not, with the Medicaid expansion, I haven't seen a lot. So I guess I'm not sure.
Fair enough. Yeah, I'm not sure either.
Claire, I have a question. On the slide where you have shown no difference, and there was quite a few outcomes on your axis that really did not show difference between the two categories because you made them dichotomous as expanded or not expanded. Did you look within each category because what that shows is kind of an average over all those states. Within each of those categories, were there differences between the states that belong to the category of expanded or the category of not expanded? Was that visible? Because you would then have just people, not states, that you would be comparing.
I don't know if I understand exactly what you're asking. So we do, the analyses are at the individual level. But so
but
I think I don't understand your question.
Okay, so you don't have the data for pre-expansion for them, do you?
We do, yeah.
You do. So you could, within the state, within any of those states, compare the pre-expansion to post-expansion within the states that belong to the expanded category versus non-expanded. So obviously, you divide the 50 states into those groups. I was just wondering if it is uniform across the states. I would assume it would not be, okay?
Yeah.
And then when you, go ahead.
We could do that, yeah. That would be more descriptive. The difference in difference is supposed to take advantage of the fact that you have a control group. So if you're just looking within states, then you don't have a control group because everyone in the state is either impacted by the policy or not. So we could do that to see if, maybe in some states you see that, things changed more after the expansion or not.
That's all. I was just interested.
Yeah.
Okay. The usual
We haven't done that, but we could.
Yeah, no problem.
I have like a general question.
Sure.
No, you said in the end how healthcare isn't the only thing that is contributing to these health outcomes, and I know one of the things. Well, I was wondering if you have any plans or if there are people looking at more like specific geographical location and are they in a food desert or are they like near a hospital, or do they even have access or a way to transport themselves to go to like a medical go receive medical care?
Yeah, good question. So people are looking at all kinds of different things related to, especially, preterm birth is of a lot of interest. So, I think that people have looked at, food deserts, almost every conceivable possible predictor of preterm birth. I don't think anyone feels that, oh, we've figured out like what causes preterm birth or what doesn't. With some of the other, maternal morbidity and mortality, those are, I think there's less work on those and it's more of a newer field. So I think we maybe know a little bit less. I am working on another study looking at different types of healthcare services in rural and urban areas. So that's definitely another area of kind of interest, as you mentioned, like, how far do people have to travel? I think that is thought to have potential impacts on maternal morbidities, which are, kind of negative health outcomes that happen around the time of delivery. So distance traveled would be more likely to impact kind of those like really specific labor and delivery related outcomes. Whereas things like preterm delivery are thought to have a whole lot of different things that impact them. So, diet and stress and inflammation and infection and lots of different things.
Thank you.
Yeah.
Hey, Claire, great talk. I was curious, thinking about this in I've been thinking about this with prescription drug monitoring programs, and there's always other policies that are happening at the same time, like cannabis legislation and things that may affect similar outcomes. I've read a lot of Medicaid expansions and things like that, but do you think of things that are also happening at the same time policy-wise that you're trying to think about and take into account, and what might be impacting some of the results that you find as well? I think that's one of the things that I'm struggling with sometimes.
Yeah, that's another good question or good point. So yes, I think there's, I think it's problematic with really all research, but policy research in particular, that we usually just focus on one policy and we don't think about other policies that could be changing. So I think like the simple, analytic fix that we usually try to do is that we put, in these analyses, we put in an interaction between state and time. So anything that's changing over time, unique to a state, is kind of controlled for. But that's not great. That's just kind of like, we're trying to get rid of that variation. But my research group just actually read a paper about this, and that we're talking about, which is like how to determine whether there's clusters of policies and then what to do about that. And I think it's a working paper, but they propose, different things, everything from like Bayesian analyses to using, I think it was like structural equation modeling to come up with like latent like classes of policy changes to, I think if there's a specific policy, you can control for that too. But typically, like you're mentioning, a whole set of like drug related policies. I'm talking about healthcare policy. Like oftentimes I'm not even aware of the kinds of policies you're talking about, and you may not be aware of these kind of policies. So yeah, I think that's like a kind of a direction that my group is interested in going in, is trying to figure out like, how can we address these multiple policies?
When you figure it out, just let me know.
I can send you the paper and you can figure it out and let us know.
The one other thing that I haven't used this method, but has been introduced is this autoregressive method where you don't have to have as strict of assumptions as in the traditional difference in difference models. and you can kind of model the kind of time series a little bit kind of better. So I don't know if those kind of methods might be able to help us in the future, but yeah, if you have any experience or know about that, that'd be great to hear about too, or think through.
Yeah, if you're talking about what I think you're talking about, like time series methods are usually more, so it's more ecological. So you have like rates of an outcome and then you have comparison groups, and you're getting rid of like all kinds of time dependencies. So secular trends, seasonality, and then you're looking for, if you have this group where you think there was a policy, you might expect the outcome to like jump up right after the policy, or jump down, or start to go down.
Right.
And so those are really powerful, I think, for causal inference. However, they require a lot of data points. So what I've always heard is that you need 50 time points to do a time series analysis. I don't know if that's always true, but we don't usually have 50 time points exactly. I mean, maybe if we did it by month, we might.
I have a comment or a question sort of thing. Before I came here to be a student, again, I worked doing Medicaid outreach, like helping people get Medicaid and get access to it and deal with those hurdles. And one interesting thing about your presentation was the postpartum like overdose drug use you were talking about. So anecdotally, I worked with quite a few people who were in long-term recovery and then started using substances again after going to the hospital for like car accidents, like emergency situations. And I wonder if there could be a similar mechanism after giving birth. I've just never thought about that before.
Yeah, that's a good point. There was a study, but I forgot what the findings are. But there was a study where they were trying to look at prescription of opioids after delivery. I think it might have been focused on cesarean deliveries, where people might be prescribed opioids for pain. And they were trying to look at that relative to, like how many people kind of kept using a really high amount that wouldn't be expected afterwards. But I don't really remember what they found, if there was some relationship between like deliveries, as I think what you're suggesting is like going to the hospital, having something painful happen to you, and perhaps being prescribed opioids or something else might lead to, other problems with substance use.
Yeah, it's just very interesting. Thank you.
Yeah, I'm curious. I'm sure you have so much insight into this, like when people, because we sort of discussed this at some point, like, once people find out they're eligible for Medicaid, like how long does it really take for them to, get in the system and get an appointment with a doctor if they want one?
A long time.
Yeah.
Sometimes over a year if nobody's accepting patients. Yeah.
Yeah. So that speaks even more to Nigel's point about how long these policies might take to actually improve health.